Yes guys, what hydroxyurea does is it affects the erythropoiesis in the bone marrow and it causes production of RBCs with relatively higher amount of hemoglobin F. Traditionally we always study hydroxyurea. What it will do is it will increase the value of hemoglobin F. Hi guys, welcome back. Good to interact with you guys again. And what I'll be doing is troubleshooting with respect to the MCQs of the recently conducted INI-CET May 2022. The paper was a little, I would say, atypical in a sense that actual general medicine questions were relatively lesser. But let's dive into the data and let's see what they actually asked. The very first question said which of the following is not associated with development of central cyanosis. If you look at option number A for this question, methymoglobinemia, this would be an example of a condition that would be causing anemic hypoxia. You very well know that methymoglobinemia would be seen in industrial workers, and this would be mainly with respect to exposure to nitrates. Now, once the oxygen carrying capacity of the blood will reduce, it is going to result in development of central cyanosis. The main point is that the amount of oxygen that is going to be carried is relatively lesser thanks to Fe3+, because traditionally in the iron atom we have Fe2+, but in this case the nitrates have oxidized this to Fe3+, and therefore we have decreased oxygen carrying capacity that explains central cyanosis. However, if you look at subsequent option, hypothermia, this would be commonly seen in, let me say, soldiers posted at Siachen Glacier, and they will be having, I would say, a localized cause of vasoconstriction, and therefore the possibility of peripheral cyanosis in these patients will definitely increase. So this looks like a possible answer to this question, but let's look at option number 3. If a person goes to high altitude, then the higher you go up, the lesser would be the oxygen concentration, and therefore the type of hypoxia that would be seen here would be hypoxic hypoxia. The total amount of oxygen in the body is relatively lesser here. Again, the difference from methymoglobinemia would only be that in option A, the oxygen delivery is reduced because of the carrying capacity being lesser, but in this case the total supply itself is compromised because at higher altitude the air would be relatively thinner or rarer. When you look at option number D, pulmonary AV malformation, this would be responsible for mixing of blood. Now, traditionally, we read about mixing of blood with respect to cardiac heart diseases, like we read about right to left sided shunt. I can say that pulmonary AV malformation is an extra cardiac shunt, and this is causing mixing of blood, and you very well know that mixing of blood would be contributing to central cyanosis. The message is option number A, C and D. They're all responsible for development of central cyanosis, but when it comes to hypothermia in a patient, there would be a localized vasoconstriction. So mainly the tips of the fingers or the toes would be turning blue, or in some cases maybe even the tip of the nose or maybe the earlobes might be affected. Concomitant frostbite can also be present, but hypothermia per se would be the answer to this particular question that I have discussed with you here, because it said not associated with central cyanosis. A, C, D definitely result in central cyanosis. Moving on to the second question, he talked about a diabetic patient presenting with palpitations. The blood pressure on admission is 122/80. Now, initially, when you read about a diabetic patient having a cardiac issue, you think it could be myocardial infarction. It could be like a silent MI, because diabetics anyway, due to neuropathy, may not be perceiving chest pain. But the blood pressure of the patient is, I would say, in the normal range. Normally in MI, there's going to be a lot of sympathomimetic stimulation due to the chest pain component. So unlikely that this is a presentation of MI, but let's scan through the ECG. The first and the foremost thing every time you are given an ECG in the exam is to look at lead number 2, that is the rhythm strip. And what you're supposed to do is count the number of large squares between the R and the R waves, and do not do it once, but try to do it at least twice or thrice. Now, every time when I'm scanning and looking at the RR interval, this would be in the range of about 1.5 large squares, and therefore the heart rate of this patient would be 300 divided by 1.5, which mathematically will turn out to be 200 beats. So the heart rate of this patient is definitely faster. Now what I'll focus on is the Qrs complex duration per se. So when you look at the Qrs complex, I would say that normal Qrs complex is about 80 to 100 milliseconds, and this would be about 2 to 2.5 small squares. So in this particular case, I can say that the QRS complex looks to be either normal, or I can say it looks to be on the lower side of normal. So definitely I need to consider that, is this patient suffering from a ventricular or a supraventricular tachycardia? You all know the hack that in every time there's a ventricular tachycardia, there would be ectopic focus in the ventricles, which would contribute to premature ventricular contractions that results in a broad QRS complex. You see, heart rate is not dependent on the QRS complex. Heart rate is dependent on the RR interval. In this case, I said the QRS complex is on the lower side. Also, you will notice a presence of ST depression. In fact, I'll just use a different color to highlight the ST depression present in this patient, and that's present universally. I mean, if I am using different colors, and I can just take a few seconds to highlight that this is the anything that goes up is R, anything that comes down is S. So I can see is a RS complex followed by ST depression, and then you are seeing a particular wave. Now this wave per se is formed by the merging of the P and the T waves. So per se, what I'm writing also here is an important diagnostic criteria that would be hidden P waves in this patient, in a sense that the P wave of the subsequent complex merges with the T wave of the previous complex. In fact, if you go through the video lectures, I've highlighted this in the topic of paroxysmal supraventricular tachycardia, that what happens is, and you can just cast a glance at this representation here, and you can see that the T is merging with the P, and that forms an important diagnostic criteria. So therefore, there are three things that what we have discussed here. Let's just do a quick recap here. First and the foremost, there's a tachycardia component present. The QRS complex, especially the RS complex, is on the lower side of normal. There is a ST segment depression present in the patient, and there is hidden P waves. So all of these features that I've written on the slide at the moment help us narrow down to the diagnosis of PSVT, a paroxysmal supraventricular tachycardia, which may even be written as AV nodal reentrant tachycardia. Now, a lot of students commented that, sir, when we actually got the ECG in the exam, we had a look at AVR. Now, traditionally, you're not supposed to look at AVR. You're traditionally supposed to, first count the heart rate, go for axis, then check out the normal sinus rhythm, as I've highlighted in the routine video lectures. But a lot of people said, sir, straight away, there was a very prominent kind of a ST elevation present in AVR. Now, this may not be an actual representation of what ECG was given in the exam, but a lot of guys gave me a feedback, sir, because there was ST elevation in lead number AVR, we thought it could be a ST elevation MI. My point is, for diagnosis of MI, we had that pattern, no? We need to follow pattern in the leads, like whether it's an anterior wall MI or whether it's an inferior wall MI. So even if you thought it is a ST elevation MI, what you need to do was have a look at the chest leads of the patient. And even when you look at the chest leads, the moment you move on to the lateral leads, and I'll just zoom it in for your convenience, if you look at these lateral leads that I have shown here, you will notice that there is still a presence of ST segment depression present. So why is there a global ST depression in patients who are suffering from PSVT? That's because the heart is suddenly beating very fast. So the oxygen demand of the heart increases, and that results in a global ST depression. I mean, that's an important statement to be remembered in all patients of PSVT. Sudden increase in oxygen consumption results in a STD, and therefore this particular patient is having PSVT, but the blood pressure is stable. So what I'm going to do in this case is going to give adenosine right away. Obviously, the first step is going to be carotid sinus massage, when I wait for my nurse to load up a 6 mg of adenosine that I'll be giving to this patient. But why not option number B? Because cardioversion is always done when the patient is hemodynamically unstable. Like suppose if this question, and they have done this actually in the previous INI and the INI-CET and the previous AIMS exams, that they've given a ECG of PSVT, the identical to the one that I've just said here before you, but it was a hemodynamically unstable patient. So that's when cardioversion would come in. I mean, systolic blood pressure less than 90/60. When it comes to amiodarone, we use it in ventricular tachycardia. We also use it in atrial fibrillation for rhythm control. And percutaneous coronary intervention is anyway used for patients who are having a STEMI. You are very well aware that there are two terms. One is primary PCI for ST elevation MI and delayed PCI for non-ST elevation myocardial infarction. So we could easily rule out the remaining options. And for PCI I'm not written anything. That's fairly obvious. I mean, everybody is familiar with percutaneous coronary intervention per se. So I'll just zoom into this ECG for one more time so that in case this question is repeated in the forthcoming exams, you get it spot on. A global ST depression. I'm just adding that word to highlight that majority of leads would be showing it. And yes, the reciprocal lead AVR is going to be reciprocal to, let me say, AVL per se. So there would be a ST elevation present. Narrow Qrs complex tachycardia with the features which are highlighted here is always to be answered the way I have mentioned, and therefore depending on the blood pressure values, the answer of yours would be given in the exam. And the same thing has been discussed in the app as well. Hemodynamically stable patient, the approach would be carotid sinus massage, and then subsequently giving the patient adenosine for chemical cardioversion. But if it is hemodynamically unstable, we are gonna go ahead with cardioversion. Difference between cardioversion and defibrillation is also what I've highlighted, that cardioversion is always going to be synchronized to the R wave, but defibrillation is going to be non-synchronized DC shock. And I would suggest you to listen to the emergency medicine video ACLS to get a better hang and understanding of the cardioversion and the defibrillation component. Now moving to the next question. I presume this was more a physiology based question, but I've tried to do justice here. And the question said, which phase of sleep is shown below? And before I start talking about these waves which are present here, let's look at some baseline data, quick 1 minute understanding of the normal waves of the EEG, and then we come back to this particular slide again. You see, most of the time what they're going to do is they can give you a recording of polysomnography. I have discussed polysomnography topic in obstructive sleep apnea, where the patient will be subjected to not only a EEG but even an electrooculography to check out whether is a NREM stage or REM stage, and electromyography. The first and the foremost thing what I want you to notice here is that as we go into deep sleep, as we progress from NREM sleep to REM sleep, where there's going to be dreams present, vivid dreams present that might even be recalled, you will notice that our muscle tone decreases. The deeper we go into sleep, our muscles tend to relax. And we might even develop what I can say casually as sleep paralysis. You are all aware of the fact that a person might be having a bad dream in REM phase that might be called as a nightmare. This nightmare, if as a kid you ever had a nightmare, you will feel that your body is paralyzed. You will not be able to react to the situation. So the message is that as we go towards REM sleep, our muscle tone begins to reduce. But at the same time, because we are in a dreaming phase and we are having a rapid eye movement, if you look at the EOG recording, you will notice that the opposite is happening, that earlier they were relatively fine waves that were present, but now these waves will become relatively more coarse, and they will also become relatively bigger in amplitude because of the rapid eye movement. So I can just draw arrows here to bring to your notice the fact that when it comes to electrooculography, finer movements would be present when we are awake or when we are going into, let me say, NREM stage 1, then 2, and then 3, whereas coarser waves with bigger amplitude would be present in the deepest part of our sleep. So I just want you to, at the moment, focus on the comparison between these two. That's going to be almost a flat line for EMG and relatively coarser, thicker amplitude waves for electrooculography. And now we focus on the EEG component here. When you are awake, the rhythm that would be present here would be beta, and usually they'll give you a frequency. When it comes to the NREM stage 1, we would be having theta waves present, and the frequency tends to become relatively slower, that is 4 to 7 Hertz. It's unlikely that in the exam he would expect you to pick up theta, because he has to give some comparison, some baseline, so that at least you can pick up. If there's a transition occurring, like from a beta to a alpha and then to a theta, then it makes relatively more sense. But as you move on to NREM stage 2, you will notice a particular pattern which I would like to hand draw before you. So keep your eyes on the sketch that I make. When it comes to the EEG of the patient. Now this is what I'm doing. You will notice that I have increased the amplitude suddenly of the waves, and then subsequently what I'm going to do is draw a fairly biphasic wave here before you, like the way it is sketched, or let me just try to make it as real as possible. So just making it having a variable amplitude but a biphasic wave. Now, how to understand this? To understand this, you can yourself draw like, something like a eye, and then if you just try to fill it up with these waves here, you will notice the fact that the waves in the middle of this eye that I made, supposedly eye structure that I made, those waves were relatively bigger, and towards the, the canthi side, the waves are relatively smaller. So this that I have tried to show here before you is what is called as a sleep spindle. So actually a couple of guys said, sir, I think it was NREM stage 2. So my question to them when we were discussing this after the exam on the Zoom session, and all these guys, actually most of them, who joined, did manage to get good ranks. So they said, sir, this was definitely not a sleep spindle. Initially they said, it might be NREM stage 2, but when I drew it before them, they said, sir, it's unlikely, because this was the representation for NREM stage 2, where you can be having is a sleep spindle, once again shown here, and then subsequently this biphasic wave, or rather having multiple variable amplitude that I've shown, is called as K complex. So if this was present and you were able to identify it, great, but I don't think so. I mean, based on the feedbacks that I drew from discussion with students. Then we move to NREM stage 3, which is slow wave sleep, where you get one of the slowest waves in the EEG, that is the delta waves, and they would be having a relatively large amplitude, and the frequency, you can notice a much slower waves present. The frequency has dramatically reduced. In fact, I have highlighted this, that one of the slowest waves in the EEG is delta waves. However, in the exam, what they gave was sawtooth waves. So when I spoke to my students, they came to this conclusion, most of them, after this discussion that I was having with them, that what they could actually pick up was three things. The first thing they noticed was this EEG pattern, which was having variable amplitude and was pretty spiky. So most of the guys said, sir, we then had a look at the EOG. The EOG of this was relatively coarse with big amplitude, and the biggest giveaway was that the EMG of the patient was almost like a flat. Obviously it can't be a flat line, but it was very fine. Now, based on whatever I have just drawn here before you, let's have a look at one of the images which one of my students sent me, and you can look at the EOG, the EMG component, and the EEG component. You will notice that when it comes to the EOG, these vertical spikes represent the rapid eye movement, but when this is happening, the EMG is literally flat, and then is this classical term that has always been discussed. I mean, we traditionally study about sawtooth waves with respect to patient in ECG, that is for atrial flutter, but when it comes to sawtooth waves with respect to EEG, then this is going to be a REM phase of sleep. So the answer to this question would be option number A, but I'm definitely open to discussion. So if you feel that the actual EEG in the exam had sleep spindles, or it had those K complexes, do let me know. Otherwise, most guys came to the conclusion, and I personally feel why this is also the probable answer is because traditionally they have asked this in theory earlier. If you go through the previous year questions of the AIMS exam, you will notice lots of time this question coming up. Sawtooth waves on EEG are found in, that is, REM sleep. So I think they try to pick that up only, and whenever they would expect you to pick it up, that would be a combination of these three things here. That is, the EOG will be showing relatively crude and bigger spikes. The EMG would be as close to the baseline as possible, and smaller amplitude waves, and the EEG will be showing this polyamplitude waves, which we can call as a sawtooth pattern. So the answer turns out to be option number A for this question. And just if you can take a picture of this, I think you would be in a better way. When you practice it by yourself, you need to try and draw it at least once, the sleep spindle part and this biphasic waves for NREM stage 2, you would be having a better orientation and a better way of, I would say, a better approach to solving the question if it is repeated. Then they also ask in the exam the various diseases that would be occurring with respect to the various phases of sleep. You all are aware of it. Obstructive sleep apnea with respect to NREM 1, then teeth grinding bruxism with respect to NREM stage 2. Then is night terrors. In fact, that's the main point which I want you to remember, that night terrors and nightmares, the questions are going to be different. If he says night terrors, then your answer would be NREM stage 2, but if he says nightmare, then it would be REM sleep, and that's also related to major depressive disorder. Moving ahead, These are normal EEG waves which are already discussed in EEG and the epilepsy section. So if we can just go through it, you would be having a better approach to solving these questions if they're repeated again. The subsequent question said a patient with a history of fall with a blunt thoracic and a blunt abdominal trauma. I double checked this. I mean, this my student said, so both these words were written like this only: blunt thoracic, comma, blunt abdominal trauma. Both terms were written. It was not slash. It was both of them terms written, presented to the emergency services of AIMS New Delhi. I mean, precisely this line was present. And then he said there are a couple of x-rays of the patient that are shown. And he said, in which of the following would you be needing an additional workup before putting a intercostal drainage tube? So when you scan through the images here, in fact, I'll just zoom it in. The first and the foremost thing what I can notice is a lung which is collapsed in this case. And this particular area is devoid of any vascular markings. The lung is looking more black than normal. I mean, if you compare this with the contralateral side, I can say that lung vascularity is hampered. This area of the lung looks relatively more bigger. I would say more black, in fact. And I can also highlight what can be written as deep sulcus sign. So there are two things which are favoring pneumothorax. One is a deep sulcus sign. The second is going to be devoid of vascular markings. The X-ray looks more black. I mean, X-ray is anyway black. No, it's looking more black than normal. So the combination of these give credibility to the fact that this gentleman had trauma to the chest and then he ended up with pneumothorax. That's definitely a requirement for intercostal drainage tube. But if you look at image number 2, you can see some shadows with respect to the left side primarily. I mean, that's what my students told me. It was mainly focused on the left hand side. And this looks like probably, maybe bubble loops going up in the chest. Or at least what could have happened is that the person could have had injury to his diaphragm. And every time there is a diaphragmatic injury so severe, thanks to the combination of blunt abdominal and the blunt thoracic trauma, that the visceral contents might move up also. So in a patient with diaphragmatic injury, I would like to do more investigations in the form of CT, more investigations in the form of a fluoroscopy. So this particular case, I will not be putting in a chest tube per se, case number 2 or the X-ray number 2 per se, because I would like to evaluate the magnitude of damage present, which would then decide the kind of surgical repair that would be done in the patient. So diaphragmatic injury is a situation where intercostal drainage tube would not be put directly. The first image, though this was again widely disputed, but most guys, after we had discussed this in the Zoom session post the exam, they were of the conclusion that there was a blunting of the costophrenic angle and the area was white. It was substantially wide. So I can say if there is a presence of blunt abdominal trauma, this could have resulted in hemothorax. And in case of hemothorax, yes, subsequently you might be requiring a thoracotomy, but initially a chest tube would help in drainage. I mean, there could be a combination of hemo-pneumothorax in a person as well. So for the first and the third one, I can put in an intercostal drainage tube. But for the second one here, I would need more investigations before I proceed with what kind of surgical repair would be required for this patient. So the question here says, let's read the line again. Which of the following would you be needing additional workup before putting in a chest tube? That would be for X-ray number 2. And as far as X-ray number 1 and 3 are concerned, we can put in a chest tube. I mean, hemo-pneumothorax could be occurring in 2 different patients or in a single patient as well. So chest tube drainage would be warranted. The next question that came up was, I would say, widely debated one again. Combination of physiology and medicine, and I am gonna decipher it before you. The question mentioned regarding a smoker who has recently joined a construction company. So he's trying to make you think, okay, this could be COPD, but at the same time construction company, you're thinking, oh man, it could be occupational lung disease that could result in pulmonary fibrosis as well. The patient is having worsening of dyspnea and the flow volume curve is shown with results as well. One, that when I spoke regarding the flow volume curve, there was definitely a concavity present, because you see there are 2 curves that you can see on the slide at the moment. I'll just zoom it in more. One you can see is the red curve and the second one is the green curve. So they gave 2 situations. One was before bronchodilator. We'll talk about the mathematical values here also. The the pre and the post bronchodilator ones, but there were two different curves, and what was happening was that this concavity was becoming relatively lesser, so goes in favor of obstructive airway disease. Now, how do you read these mathematical values? The first and the foremost, there were values given of FVC, FEV1 and FEV1 FVC ratio. When you're given values like this, the first thing what you should notice is what is the FEV1 FVC ratio, because every time you are gonna read a FEV1 FVC ratio less than 0.7, it's gonna tell you that you're gonna deal, or you are dealing with the obstructive pathology. And in this question, you very well notice the value given is about 68, and then subsequently after giving a bronchodilator, there is a improvement in the condition of the patient as well. And let's look at FEV1 value also. These values may not be the actual ones that came in the exam, but I selected a image from the textbook which was very close to what was actually asked. If you look at the FEV1, it was before, in fact I'll just zoom it more so that it's more clear on your mobile. It's 3.55, post bronchodilator is 4.64, so there's definitive increase of about 30%. Why that's important is because every time when I have spoken regarding reversibility of airflow obstruction, the reversibility of airflow obstruction, what I've explained is that the value should be more than 12%, and in this case we have had a very excellent response going up to 30% in the patient. Another thing that you must look at in these reports is the FVC value. You can notice that mathematically the FVC value has increased from 5.18 to 6.06. Why that is important is because if it is restrictive airway disease, then this FVC will not change. If a person is having restrictive airway disease, then FVC post bronchodilator is not gonna change, and you will have to do a DLCO in the patient subsequently. But in this particular case, there are multiple pointers towards obstructive airway disease per se. One is going to be the shape of the flow volume curve, FEV1 FVC ratio less than 0.7, a dramatic increase going up to as much as 30%, and even an increase of FVC, which is not going to be increased in restrictive airway disease. So this means that this construction company thing that was given was a distraction. This rules out restrictive pathology with respect to this question. We're left with two, obstructive etiology with or no response to bronchodilator. So if the values are increasing, especially if FVC is increasing, it means that there is a response to bronchodilators. The answer to this question would be option number C. The main point, every time they give you these mathematical values, I'm just going to show this once again. Every time they're going to give an image like this in the exam, they would be giving you mathematical values also. First, look at FEV1 FVC ratio. Look at it whether it's less than 0.7, and the next thing that you need to do is obviously check out mathematical increase in the value of FEV1. As you can see, 4.64 divided by 3.55, it would turn out to be little more than, definitely more than 12%. And third, look at, they might be given in any order, like in ABG I tell you always look at pH, PCO2, bicarb, always follow that rule. Similarly here, look at FEV1 FVC ratio, look at FEV1, then look at FVC, and if it's showing an increment, you are bang on correct with respect to obstructive pathology. And obviously flow volume curve also gives justification to this. Coming to the next question, it talks about which of the following statements is incorrect with respect to prophylaxis in AIDS. Option A talks about PCP prophylaxis when CD4 count is less than 200. So you very well know that when the counts are less than 500, the opportunistic infection that is seen is tuberculosis, but the values go less than 200, it is Girovasi, and that's when we treat the patient with cotrimoxazole and we start prophylaxis also, so that the moment the CD4 count will go more than 200 for at least 3 to 6 months, then we can discontinue. So this looks like a okay statement, this looks like a correct statement, and in fact I have discussed Girovasi in HIV topic, and even separately with respect to pneumonia. And before I go on to the remaining options, I just want to say that I got a message actually from one of my students. He got about I think 1213 rank in this May INI-CET, and he messaged me that, sir, one day before the exam I read AIDS topic, and then luckily question came. So he is able to crack it, and let's look at his thought process, because I was very interested in knowing how did you, or how were you able to solve it. So option number A makes sense, because you see if the count is less than 200, that's when you should treat the patient and then start the patient on prophylaxis, because you don't want him to suffer from the disease again. When the counts go to less than 100, that is when cerebral toxoplasmosid would come up, and this is an intracranial space occupying lesion involving basal ganglia, and seizures would occur. When the count goes to less than 50, then there are two problems. One, this patient can go blind, there would be cytomegalovirus retinitis, and there could be exposure to atypical mycobacteria, that is Mycobacterium avium intercellulare or Mycobacterium avium complex. So option A and C are looking like correct statements, because that's when we read the CD4 count decreasing in a AIDS positive patient. These are the common infections that we study, and if the values are lesser than this, then prophylaxis would be warranted. If we look at option number B, he says stop if the count is more than 350 for 2 consecutive times at an interval of 6 months. Now suppose I'm reading this option number B for first time in my life. The thought process of mine is either there could be a trick with respect to this value. It could be maybe 200 instead of 350, and this interval could be maybe 3 months instead of 6 months. But overall, this looks like a okay statement, primarily because if the count would go in excess of 200 going up towards 500 for a duration of 3 to 6 months, it makes sense to stop the treatment in the patient with respect to prophylaxis per se. So what I'm saying is I'm putting a plus minus at the moment because I've still not read option number D. Option number D says cryptococcal meningitis, cryptococcal prophylaxis should be started when CD4 count is less than 150. Now I'll give you two reasons why option number D is a wrong statement. Why I'm saying is a wrong statement is because, one, I have discussed cryptococcal meningitis twice in the app. One with respect to neurology, where I've talked about meningitis. I've talked about treatment, but I've not talked about prophylaxis. And even in the AIDS topic, I've talked about treatment because primary and secondary prophylaxis is not given in cryptococcal meningitis. The textbook says that you should be giving this prophylaxis only if there is a previous episode. Only if there is a previous episode documented of cryptococcal meningitis that there is a requirement of prophylaxis. So when you look at this statement, it says it should be started when CD4 count is less than 150. I mean, if I'm reading this statement for the first time, I mean, this value 150 will sound a little fishy to me, a little, suspicious to me, because traditionally we read about those mathematical values that I've written at bottom. There are two reasons why D is the answer to this question. First and foremost, I can just say is that I've not talked about prophylaxis in patients because primary and secondary prophylaxis is not recommended. And the second reason is I'll show you a reference from Harrison. So let's look at what Harrison says for cryptococcal neoformans. I'm zooming it in. He says, and read the words carefully, this is for the start and this is for the stop. And he says only if there's a prior documented disease, which I have highlighted. He says stop if the values are more than 100. He says stop, remember this mathematical value, because I'm going to come back to the previous slide. This is an indication for stopping. Whereas what did he write here? I mean, I think this is what he took in the exam from where the question was created, that the value is more than 100 for stopping. And look at what he said. He said you are to start when the value is less than 150. You stop when the value is more than 100 per se. So I gave you two reasons. One, I said that only in prior documented disease are you supposed to, give the treatment to the patient. Otherwise, there is no need for primary and secondary prophylaxis. And second is this mathematical value that looks a little fishy, little suspicious, and even the textbook says the same. Now, a lot of students, they said, sir, we need a reference for this statement, which you said is a correct one, that CD4 count when it is in the range of about 350 for 3 to 6 months. So I could not find a textbook reference for it, but there's obviously a credible government website, that's clinicalinfo.hiv.gov, and this mentions it, because what I have read is 200. But this mentions that if it's in the range of 200 to 350 for 3 to 6 months, then we can say that the therapy can be stopped in the patient. This is primarily for the indications for discontinuing and restarting prophylaxis in AIDS positive patients. So coming back to the options of this particular question, you can very well see that option number A and C, they are easily ruled out, and option number B is a okay statement and a given reference for the same as well, and therefore the answer to this question will be option number D. The next question was having a pediatric overlap. Traditionally we read about MDRD formula or Cochrane Gold formula, but this said EGFR for a boy aged 4 years. Weight of the child was also given and the height of the child was also given. And for pediatric age group, we don't take into consideration the weight, but we take into consideration the height of the child. I'll show you a reference from Upighai, which says that to calculate the GFR, we'll be taking a kappa value multiplied by height divided by the serum creatinine. This kappa value will be ranging in the range between 0.41 to 0.43. So let's take up, let us say 0.42 as an average. You have to multiply this by the height, which was given to be 100 centimeter, right? And the serum creatinine of the patient was 1 milligram per cent. So if you look at it, this would turn out to be approximately 42 ml per minute. And let's have a look at the options. The closest answer for this one be 40 ml. By Cochrane Gold formula, actually, a couple of guys said they did not mention about the age of the patient. Like they did not say it was a pediatrics question. When I got this question from my student initially, the age of the patient was given to be adult. And by Cochrane Gold formula, when you were talking about somebody in 20s, it was turning out to be value of 30. So, lots of time, in recall, there is paucity of the correct information that can result in erroneous interpretations as well. But this was a pure, I would say, hardcore pediatrics question and directly from Upighai that they have asked, and the value is right in front of you. Moving to the subsequent question, he said this alcoholic is having withdrawal symptoms. The LFT of the patient was showing derangements with respect to liver enzymes, and anybody who's having damage to the liver, I would like to give a drug which would be having the shortest duration of action, and out of the 4 which are mentioned here, lorazepam would do the trick. The main reason why answer is C is that deranged liver function. So you need to give a drug that can be metabolized faster. I don't want the patient to be sedated for long duration. I don't want over sedation. I don't want compromise of the airway defenses to the level that he might end up with aspiration. The basic essence of medical sciences: first do no harm. The subsequent question said a tongue fasciculations would be present in which of the following. So it has to be a lower motor neuron lesion. When it comes to Guillain-Barré syndrome, it is characterized by demyelination, and the manifestations are in the form of ascending paralysis. This is a lower motor neuron type of paralysis that would be developing in the patient. They could be diaphragmatic paralysis as well. And usually when we read about GBS, it's all about quadriplegia and diaphragmatic paralysis, 7th nerve palsy, but not about fasciculations. Option number B is easily ruled out because Duchene's would be having pseudo hypertrophy of the calf muscles and waddling gait. Myasthenia gravis would be a female patient who would be having ptosis and would be having chewing muscle weakness, even a subsequent myasthenic crisis, even difficulty in raising arms, but not tongue fasciculations. Neuromuscular junction defect, myasthenia gravis, has been ruled out. We are left between A versus D. Then this would be spinomuscular atrophy, and I can say this would be a pediatric version of motor neuron disease or amyotrophic lateral sclerosis. So in general medicine, it is when we read about example of there have been a lot of people that I've described in the app who have suffered from amyotrophic lateral sclerosis, and one of them is Stephen Hawking. And it was just in one of my live sessions also that I was talking about anterior horn cell disease, and I talked about fasciculations that would be occurring in the patient. And the question was asked in a reverse fashion that fasciculations are a feature of anterior horn cell disease, which is amyotrophic lateral sclerosis, ALS in fact, when it comes to adult patients, and the pediatric version of this would be spinomuscular atrophy. So the answer to this question would be option number D. This is the reference I just posted from one of the live sessions. The next question talked about serology status for chronic hepatitis B patient. I personally feel this was one of the easiest questions because traditionally for hepatitis B, they go into remote infection and they try to talk about those situations where surface antigen is negative. I mean, if I look at INI-CET papers of the previous 2 years, every time they've asked about hepatitis B, they've tended to ask something which would be right at the bottom of the table, which is remote infection. But this time they made it pretty easy. It would be surface antigen positive and IgG class of antibody to the core antigen, and I can pick this up in the bottom 2 options because A and B are surface antigen negative anyway. When I look at option number D, you can pick up it would be surface antigen positive. Security system has still not developed in the patient. I mean, the security system is sleeping, that's why there is damage. The damage is in the form of documented by IgG class of antibody to the core antigen, and the virus is replicating. DNA, hepatitis B DNA positive, so virus is still multiplying because security system is sleeping. No, that is why there is a damage present and the virus is still multiplying. So this would be a chronic active hepatitis, and therefore this option, the last one, option number D, will be the correct answer for chronic hepatitis B serology. And personally, I actually did not believe when a student told me that this came in the exam. I thought, I mean, maybe he interpreted it wrong, but then everybody said, no, this was the actual question. Another AIDS question which people were able to solve was all are AIDS defining tumors except Kaposi sarcoma, invasive cervical cancer, yes, caused by human papilloma virus 1618, the one you that study in gynecology, non-Hodgkin's lymphoma of the immunoblastic subtype that involves the brain are AIDS defining cancers, but definitely not melanoma. So the answer to this question is again the last point. The next question has a pediatric overlap. As I said, traditional general medicine was lesser. The child is born to a HIV positive mother in a hospital. Which of the following is best to be done? Now, I'll show you references before we come back to the options in this case. The references are from OPGI only, so I'll just zoom it in. One of the options clearly mentions that if a mother has received triple ART during pregnancy and entire breastfeeding, the infant should be receiving either zidovudine or nevirapine until 6 weeks of age. So that's one data, nevirapine up to 6 weeks of age, irrespective of the feeding status. And let's look at what the guidelines are with respect to breastfeeding even in OPGI. He mentions the fact that exclusive breastfeeding is recommended. Obviously, after 6 months, it's gonna be we can be giving complementary feeds to the child, but you very well understand that if you do mixed feeding, I mean the main problem is that mixed feeding will cause a problem. If you give a combination of breast milk and cow milk will cause constipation, mucosal tear, and after that or over it, when you give breast milk, the virus would be transmitted because virus is anyway present in the breast milk per se. But he says that exclusive breastfeeding is recommended in even a HIV positive child during the first few months of life. So coming back to the options here, I am removing two options from the discussion. One that I'm removing is with respect to alternative source of feeding, because there were two options with alternative source of feeding, and in one of the options he had mentioned regarding testing also to be done in the child. We are left between A and C. Then option number C says exclusive breastfeeding, nevirapine to be given even the child is positive, and option number A says to be given even if the child is negative. My point is that these tests for detection of HIV, especially in a pediatric case, may not turn positive immediately. I'm not gonna wait and say that okay, only if the test is positive I'm gonna give the medication. I'm gonna presume the child is infected and I'm gonna give nevirapine for 6 weeks so that we can reduce the chances of the child turning HIV positive. And therefore the correct answer for this question is option number A. The logic behind this is that reason number one would be that the tests which are done immediately after birth may not be able to pick up the real situation, whether the child got infected or not, because you very well know the chances of transmission can vary in the range of 30%. So child may be infected, may not be infected, and even the test may not be able to pick it up. So I'm not going to wait that only if the child is positive, a child born to HIV infected pregnant lady is born positive, that we're going to give nevirapine. We're going to give it universally even if the child is negative at the moment, and that would be given for 6 weeks. Therefore, the answer to this question is option number A. And in case you find any discrepancy in this question with respect to maybe PSM or pediatrics, do let me know. I mean, my email is marwahmedicine@gmail.com, and I would be glad to assist you with this particular question. But I've shown references from OPGI which make sense here. The next question said a client is admitted with the unknown poisoning. There's nausea, vomiting, skeletal muscle spasms, seizures, diaphoresis, lacrimation, lots of things happening. So I need to, put pointers there like diaphoresis, lacrimation. So this looks like there could be muscarinic receptor stimulation, but then there's a tachycardia also, which means that there is a nicotinic receptor stimulation as well. What he's trying to point is there could be sludge symptoms in a patient, and there could be nicotinic receptor stimulation contributing to tachycardia, and then subsequently a polyuria in the patient as well. So this is a case of organophosphorus poisoning. And in OP poisoning, The antidote primarily that we'll be using in this case would be atropine. The answer to this question would be option number B, and you just had to pick up the manifestations here. The next question again has a pediatric overlap. There's a kid with recurrent bloody stools, atopic dermatitis and petechiae over the extremities. CBC shows a TLC that's normal, but platelet count is low. And my first thought process was this could be ITP, that is idiopathic thrombocytopenic purpura. And I was thinking about, yes, I should be going in for maybe a bone marrow study in this patient. I mean, in ITP, the bone marrow will be showing megakaryocytes, which are bigger in size. I mean, megakaryocyte hyperplasia would be seen primarily. But then what caught my attention was this word atopic dermatitis, like rash in these patients. And the gender was also given to be a male. So I was asking to myself, could this be Wiskott Aldrich? And can I comment on Wiskott Aldrich directly? I mean, it looks like, okay, ITP present. So I thought it could be maybe some kind of antibody testing or bone marrow aspiration. But then these 2 pointers, because we know that Wiskott Aldrich is common in boys, and initially there could be a skin manifestation in these patients as well in the form of atopic dermatitis. I mean, this is the main contention, that should I think in terms of idiopathic thrombocytopenia purpura, which is a common presentation, versus a rare disease like Wiskott Aldrich. Let's look at what Upigai says about it. He mentions that eczema begins early in infancy, mimics atopic dermatitis. I mean, he's mentioned it right away with respect to this X-linked disorder. And yes, there is a thrombocytopenia. There are small size platelets. Now, in the exam, there was no mention of small size platelets. But since this clinical manifestation is highlighted in the textbook, so we have to give credibility to this. And the thought process of the examiner here is not rather a common diagnosis, but rather I would say a fancy diagnosis of Wiskott Aldrich, and therefore VASP genetic testing would be done in these patients. The next question says, a female presented in the postpartum period with complaints of palpitations, dizziness, hypotension, refractory to resuscitation. And this is postpartum period. So my thought process is postpartum and there's a crashing of BP. So there might be a pituitary apoplexy, and that would explain probably the low blood pressure of this patient. Which of the following should be used first line for the management of this patient? ACE is dobutamine. We use it in cardiogenic shock, whereas this particular case, courtesy pituitary apoplexy, there would be an adrenal crisis occurring in these patients. And this could be explaining hypotension or adrenal insufficiency occurring in these patients. And this adrenal insufficiency can explain why the BP is low and is not responding to volume expansion. So I need to give her cortisol. I need to support with mineralocorticoids, and what better than hydrocortisone, which will be having both mineralo as well as glucocorticoid activity to take care of the adrenal insufficiency in the patient. Growth hormone is a dummy choice here. ACTH, well, ACTH we do use therapeutically in one condition. That is actually a question that came subsequently, so I'm going to talk about that ACTH issues also. But in this particular case, it's a postpartum event, pituitary apoplexy, and then this triggered adrenal insufficiency, for which hydrocortisone would be used. Then the question was, which of the following is not a first line treatment in rheumatoid arthritis? The question is rephrased. Actually, if you go through the previous NEET exam questions, there is mention regarding triple therapy. Traditionally, we read about triple therapy with H. pylori, but triple therapy is what we read even with rheumatoid arthritis, and there are 3 things to be remembered: methotrexate, sulfasalazine, and hydroxychloroquine. And if you are just going to go back to this question, you will notice the same options were repeated, and they just put up azathioprine extra there. The correct answer for this question is option number A. The remaining drugs which are mentioned here are components of the triple therapy, which would be useful as management of rheumatoid arthritis. Nowadays, we do not use NSAIDs. We straight away start with methotrexate, and if there's no improvement, we need to add on to the drugs which are mentioned here. Otherwise, biologicals would be required. Do listen to the treatment part of rheumatoid arthritis, on which questions are usually asked. This question is the traditional INI-CET kind of a question, where they usually ask you to arrange things in a particular order, and is asking you the network of the direct pathway of the basal ganglia. So let's have a look at the diagram before we come back to the options here. One, from physiology, inhibition of an inhibitory pathway will always cause a stimulation. So now let's look at, if I want to write something before you on this slide, then my cerebral cortex will be firing excitatory impulses to my corpus striatum. Now, what this corpus striatum does is it causes inhibitory impulses. GABAergic neurons are activated. There would be GABA that would be released, and this would be acting on globus pallidus interna and substantia nigra. So what you need to remember is the core issue. It is corpus striatum, ST, you can write it. Then is G, and then I'm writing GP, that is globus pallidus, and then substantia nigra. So you just need to get the order right here. It is first corpus striatum. The corpus striatum is the one that is stimulated. So I'm just gonna put a plus sign on the top of it. But then subsequently what it is doing is it is causing inhibition with respect to the globus pallidus and substantia nigra. If you get this particular part of this flowchart right, you are bang on target to understand the direct pathway, which is that if there is going to be inhibition of this inhibitory pathway, this itself is an inhibitory pathway. If you have inhibition of an inhibitory pathway, there would be stimulation of the thalamus, and that could help you perform voluntary activity. So basal ganglia are responsible for execution. You know, when we read about planning, programming, execution of activity, basal ganglia play an important role. So you just need to remember the inhibitory component which is present here, and once you get SGS right, you can come back to the options here, and you can easily rule out option number B and C, which are starting from globus pallidus. You are having to select between option A and option D. Again, you can see, you know, the words are changed with respect to A and D, that it is cortex written before thalamus, which would be wrong because it's first thalamus which then goes and stimulates the cortex. So you had to just put the data in the right perspective. Striatum, then there's going to be inhibition with respect to globus pallidus interna and substantia nigra, and this in turn will be inhibiting the inhibitory impulses to the thalamus. So there would be final stimulation of the thalamus, and well, voila, there is a mechanical activity occurring in the patient. The correct answer to this is A. Question said, which of the following is not used in the treatment of sickle cell anemia? Before we look at the options, let's look at the actual video lecture. One, I've described that in sickle cell anemia there's a sickling crisis. So one of the new drugs that is given in Harrison for management of this condition is voxelotor. The objective of this drug is to reduce the hemoglobin S polymerization, because that's which is responsible for the sickling crisis and the deterioration in these patients, because sickling crisis will cause avascular necrosis of bones. It will compromise the blood supply to the heart, blood supply to the kidney, and all organs get affected in sickle cell anemia. We also have a monoclonal antibody available. This is again a new name given in Harrison, that is crizanlizumab. This again decreases the frequency of a vaso-occlusive crisis, and vaso-occlusive crisis, the origin behind that is mainly sickling crisis only. So once you get these monoclonal antibody and voxelotor right, let's look at the question now. The question was saying which of the following is not used. So voxelotor is used. I told you the mechanism of action, inhibition of hemoglobin S polymerization. So the sickling episodes will become relatively lesser. Though you would be able to pick up the answer by this particular point of time, let's also read about hydroxyurea, what it does. I mean, we always read about hydroxyurea is useful in sickle cell anemia. What hydroxyurea does is that it affects the erythropoiesis kinetics in the bone marrow. Yes, guys, what hydroxyurea does is it affects the erythropoiesis in the bone marrow, and it causes production of RBCs with relatively higher amount of hemoglobin F. You know, traditionally we always study hydroxyurea. What it will do is it will increase the value of hemoglobin F. How? I mean, it's not that the RBC is produced and it is having more hemoglobin F. It is that hydroxyurea has been documented to affect the bone marrow, and it results in modification of the erythroid precursor. So the RBCs which are produced would be having higher values of hemoglobin F, and higher is the value of hemoglobin F, then I would say this will be reducing the frequency of sickling crisis, because what you require for sickling crisis is mainly hemoglobin S. So inside a RBC, if you are having a fixed amount of hemoglobin S, but you increase the amount of hemoglobin F present, then the sickling crisis episodes would reduce. As far as the role of glutamine is concerned, it is simply an antioxidant, and it helps these RBCs which are already under stress because of sickling episodes. These RBCs are already under stress, so it helps them live better. Option A is used. It inhibits hemoglobin S polymerization. Option number B is an antioxidant. It helps the RBCs thrive better. Option number C increases hemoglobin F. neutralizes the effect of hemoglobin S, which is anyway increased in the patient because he's suffering from sickle cell anemia, and thereby I can reduce the sickling crisis episodes. But option number D is useful for COVID-19. This is a monoclonal antibody, like we read about Casirivimab and Imdevimab. No, Regeneron was the initial product that was used even on President Trump when initial episodes of COVID-19 occurred with respect to the Delta strain. So we are having these new monoclonal antibodies being developed for COVID-19, so that I mean, all those variants, especially ones which can cause deterioration in sick patients or patients who are high risk patients, can be managed effectively. So you don't need to remember the name of the antibody which is mentioned in option number D. It's just a matter of fact I said that this is a monoclonal antibody, Bebtelovimab. This is a monoclonal antibody useful for COVID-19. The next question talked about N-acetyl P-benzoquinone causes hepatic necrosis in which of the following. So if you listen to my video on paracetamol toxicity, I think this was a pharma based question, but I still kept it because even in my videos I've talked about paracetamol toxicity. So how does paracetamol get metabolized in the body? There would be two phases, and the first one is cytochrome mediated. Phase 2 would be sulfation and glucuronidation, and it's in phase 1 that NAPQ1 is produced. It is N-acetyl benzoquinone, and what it causes is a glutathione depletion, and if glutathione is less, the protective system is less, then the RBCs would undergo necrosis. So paracetamol toxicity phase 1 is the troublesome fact, and the answer to this question is option number A. Thankfully did not ask regarding whether it is phase 1 reaction or phase 2, but I'm sure you are aware of this from pharmacology. The subsequent question said patient is RK39 positive. So the moment you read RK39 positivity, you are reading about Kala-Azar. And then he says that this person is having fever which is not responding to antibiotics and ATT. He should be started on which of the following? So that would be liposomal amphotericin B. Considering Kala-Azar, the drug of choice is LAM. The next question said patient had a RTA, GCS is 3 on 15. So I mean, we are soon gonna have a brain death in this patient, but the CT scan shows a normal study. In earlier times they used to love and ask about extradural hemorrhage or intraparenchymal hemorrhage, but at this point of time you can see that a CT head of the patient is showing a normal study. That would mean a diffuse axonal injury. Again, a very oft repeated question. Otherwise all others would be having very classical manifestations like blood in the sylvian fissure for SAH, biconvex lenticular hyperdensity for EDH, or like IDLI, etc. you might call it, and cerebral contusion. Again, I mean, you would be still able to pick up hyperdensities, but option number C, CT can be normal, or they might be punctuate hyperdensities at the interface of the gray and the white matter, but because these would be very small, so CT can look normal also. The subsequent question said which of the following drugs is not used in hyperkalemia. So salbutamol is used. We use salbutamol nebulization, and what it does is it helps in potassium going inside the cells. Yes guys, salbutamol nebulization we give, salbutamol that's given here is almost 4 times more than what we give in asthma nebulization, and that causes excessive sympathomimetic stimulation. It increases blood glucose values also, it causes endogenous insulin release also, and it causes potassium to go inside the cells. And calcium gluconate anyway will neutralize the excitability component, because hyperkalemia per se causes diastolic arrest, and calcium will be causing contraction. So what I'm trying to do is I'm trying to neutralize the harmful effects of potassium on the cardiac myocardium by giving calgluconate. And insulin drip is anyway given with dextrose because it sends potassium inside the cells. In fact, option number A and option number D, they send potassium inside the cell and thereby will reduce serum potassium, but there is no role of magnesium sulfate for management of hyperkalemia. Coming to the next question, ACTH is used in which of the following? You all read this in pharmacology, that is West syndrome. For juvenile myoclonic epilepsy, we will be using sodium valproate. Rolandic epilepsy is a type of focal seizures that are found in children, and for focal seizures, we might be using carbamazepine. Lennox-Gastaut syndrome, again, this would be having combination of like there could be myoclonic seizures, atonic seizures in a patient. So again, Lennox-Gastaut syndrome, it is sodium valproate that is used. So the answer by exclusion also is option number C. West syndrome is a triad of 3 things. There's gonna be infantile spasms, which we call a salam seizure. There's gonna be hips rhythmia, very characteristic EEG thing, because you don't read this word anywhere else. Grossly chaotic EEG, and then mental retardation. So these are three features which are seen, and what they've documented is why do you have this is because there's a stress induced CRH release, and there's a effect. Then this CRH has been shown to act on the motor area, and it can contribute to seizures. Very surprising but true. He says the large CRH in these patients has been shown to actually cause development of seizures, and therefore what they did was they started giving ACTH injections, because ACTH by feedback will decrease CRH. So you would have also read, no, steroids will also be used in West syndrome, again because if we can't have off-label usage. Traditionally we'll use ACTH, and ACTH will be the answer of vigabatrin. I mean, those are the two things that they teach you, but then off-label we also use steroids if we are not able to procure ACTH injections or vigabatrin for these patients, again because steroids would be having a negative feedback and they'll neutralize the effect of CRH, which is the main trigger here. And this is what studies have shown. I mean, the reason for salam seizures is a very surprising statement actually, that gross excessive elevation of CRH can trigger development of seizures. So we wanted to bring it down, and we can bring it down with usage of ACTH. The answer to this question is C, and I've also tried to give you reason for the same. The next question said localization of lesion in spinal cord would be all of the following except. So every time there's a spinal cord lesion, we would be having combination of lower motor and long tract signs, in a sense that at the level of the lesion it will be lower motor, and below the level of the lesion it would be upper motor, and there would be corticospinal manifestations. They could be Babinski sign. Bladder involvement definitely can be seen if there's going to be a lumbosacral spine involvement, especially S2, S3, S4 if they're involved, like in chordae equina. Fasciculations, lower motor neuron manifestations at the level of the lesion, and below is always upper motor. But option number A, crossed hemiplegia. The moment you read about it, you very well know crossed hemiplegia is a feature of brainstem stroke. It's a 2-hour video, I know, but this classical term, because normally hemiplegia will be occurring like, on the contralateral side. But crossed means one side of the face and opposite side of the body. One side of the face, other side of the body may be involved. That's brainstem stroke per se. Mainly it is seen with the damage to the pons or maybe to the medulla. So answer to this question is option number A. Then the next question said, which of the following is not an adaptation at high altitude? So you see, pulmonary artery is the only artery which does not carry oxygen. Pulmonary artery is the only artery carrying carbon dioxide. So it exhibits a vasoconstriction. All arteries dilate with response to hypoxia. If you have gone to high altitude, something like Leh or Ladakh, you would have a headache. That headache is because there would be cerebral vasodilation. Those blood vessels will dilate and they might stretch the dura mater, and dura mater is the pain sensitive structure in the brain, so they can be headache. So all blood vessels dilate in response to hypoxia except one, pulmonary artery. Pulmonary artery exhibits a constriction. Plus, because of the stress on the body, there would be increase in heart rate, but because the person will be having stimulation of his chemoreceptors, and the person's respiratory rate would be increased. I mean, every time you go to high altitude, you would be breathing harder and faster. So when you breathe harder and faster, there would be carbon dioxide washout, and you would be rather having a respiratory alkalosis and not a respiratory acidosis. The correct answer for this question is option number C. The next question said, in a patient with a fasting blood glucose of 160, which of the following is the most appropriate non-pharmacological intervention? So he's talking about impaired glucose tolerance. He's talking about pre-diabetes in a patient. Though all of them look okay, I asked my students, is this a multiple correct response? No, said no sir. The question was most appropriate pharmacological advice. Decrease salt intake to less than 5 grams per day. I mean, the recommendations are less than 2300 grams per day. But anyway, because most Indian diets would be having almost 5 to 10 grams, maybe up to 20 grams of salt. So I would say option number A is okay. It is recommended for diabetes, but it would be more valid for, I would say, DASH, dietary approaches to stop hypertension. So option number A looks like an unlikely answer because that's more valid for hypertensive cases. Option number B says decrease cholesterol intake to less than 100 milligram per day. Guidelines are 200 milligram per day, but this would be a person who's having hyperlipidemia. I mean, a person who's having, let me say, deranged cholesterol, deranged LDL values, HDL is less. I would recommend him to limit the intake of eggs, especially the egg yolk component, and limit his cholesterol intake. So A and B are more valid for hypertension and hyperlipidemia, though yes, hyperlipidemia occurs in diabetes also. But the primary problem in diabetes is carbohydrate. So that is what we need to basically restrict. A and B are valid for hypertension, hyperlipidemia. C says increase fiber intake to 80 milligram per day. Yes, fiber will definitely improve glycemic control. But alone fiber, one, cannot be consumed in very large amounts because of limitation. Taste factor also comes in. So improve glycemic control is fine. But then, as I said, the main villain in the diabetics would be to restrict the amount of carbonated drinks, especially I would say products which are containing sucrose, fructose. I would like to first advise this patient to primarily go in for cereals that have a low glycemic index, and especially go in for caloric restriction, because especially in type 2 diabetes with obesity component present, if they go in for a hypocaloric diet, it improves glycemic control. The first and the foremost thing in patient would be diet control followed by exercise, and the same thing that I've highlighted in the video. Diet control is what is asked for this question. I'll also give you the Harrison reference for the same. He used this word medical nutrition therapy. Medical nutrition therapy means optimal coordination of caloric intake, which means that if the person is fat, then the person should be put on a relatively lesser amount of calories. In fact, you can see here that patients of type 2 should mainly focus on weight loss. And how is that weight loss possible? Not by only increasing physical activity, but at the same time, apart from physical activity, it should be a modest caloric reduction. So this is what is mentioned in Harrison initially for management. This is 21st edition of Harrison, page number 3146 that I'm quoting in this particular case. So it is medical nutrition therapy, which would be the correct answer for this patient. It is caloric restriction in type 2 diabetes, which would be beneficial. The answer to this question is option number D. The subsequent question was having a boy with the following lesions, and you can see lesions on the knuckles and even on the interphalangeal joints of these patients, which are Gottron papules of dermatomyositis. The answer to this question is option number A. Option number B, dermatitis herpetiformis. The lesions are mainly located on the elbow, and usually they give you history with respect to celiac sprue. Rheumatoid arthritis will produce deformities, no deformities seen here. Atopic dermatitis would be having involvement of the flexular areas, whereas here you can see the erythematous lesions, which are very circumscribed, involving the IP and especially the knuckles of the patient. So therefore this is option number A as the answer. The subsequent patient came with complaints of spider crawling over the chest. Very peculiar word that the examiner used, and yep, a lot of patients might actually not say that there are some lesions present or vesicles present or some pustules present. They might just say that I feel as if some spider is crawling over my chest, and the lesions which you can notice are in dermatomal distribution. Considering the lesions in a dermatomal distribution, the correct answer for this question would be given as option number A, that would be herpes zoster. The remaining option, herpes simplex, would be causing again grouped lesions, but that would be on the genitals, mainly related to STD. Varicella zoster would be diffuse all over the body, where you would be able to see maculo-papillovesicular lesions. And molluscum contagiosum, you have usually image of a face of a child, and then you have those umbilicated lesions present. So in this particular case, especially with respect to the dermatomal distribution of the vesicles and the erythematous rash, the answer for this would be given as herpes zoster. The next question said, which of the following is not seen in a patient of Plasmodium falciparum? It will cause cerebral malaria. So in any patient who's having cerebral malaria, there is a high possibility that he'll go into coma and thereby he will not be arousable. This makes sense. One of the important reasons of death in these patients is hypoglycemia. Yes, why hypoglycemia is dangerous is because of the high parasitemia, because these parasites are inside the RBC, so they will consume more sugar. The RBCs will consume more sugar, and therefore you would have seen that we always give antimalarial drugs along with 10% dextrose, because hypoglycemia in these patients indicates high parasitemia. These patients can be having black water fever. Black water fever implies that there would be extensive hemolysis, there would be acute tubular necrosis, because the hemoglobin will block the tubules, and blockage of tubules can contribute to serum creatinine to become elevated. But at option number C, I think the arrow was pH more than 7.25, whereas actually it should be acidosis. These patients would also be having circulatory failure, because you read about algae malaria. In algae malaria, you have a circulatory failure. And when I say person is having circulatory failure, then with circulatory failure, acidosis, metabolic acidosis component would come in. The correct answer to this question is option number C. There's a table in Harrison in which all these parameters are given. And as you can see, there would be metabolic acidosis that would be coming up. Hypoglycemia is primarily because of the high paracytemia component. So anyway, liver enzymes will also get affected. There would be coma in a patient. They can even be hypothermia subsequently developing. So multiple manifestations indicate poor prognosis in severe falciparum malaria. It's just that the arrow of pH was the one that was inverted in this particular case. And even if you don't know this, you can solve it on the basis of black water fever, cerebral malaria component, and high paracytemia, as I explained. The subsequent question, I was having a very significant paucity of information for the options here, but finally I was able to get it right. He says, which of the following is correct about anti-cytomegalovirus IgG class of antibody? Now, every time there's a IgG class of antibody, it definitely indicates a past infection, so this is okay. B says chronic CMV infection, patient is immune to other strains of CMV in future. I can give example of COVID-19. You might have had COVID-19 once, you might be having antibody, but that does not mean that Omicron BA1 or BA4 would not cause problems. I mean, people had Delta, then they had Omicron. So, I mean, chronic CM, I'm giving parallel here, like somebody is having antibody against COVID, he can still get infection with the newer strain. So same in cytomegalovirus also, that why this is a wrong statement is because of the fact that even if a person is having this antibody, it does not mean that the person is immune. What is wrong about this statement is this statement: patient is immune to other strains. If he will get infection from other strain, he can get infected and he will show manifestations also. Another reason why, I can say why B is a wrong statement is, you would have seen that people would be having antibodies against cytomegalovirus, but after kidney transplantation, when they put on immunosuppressive drugs, they still develop cytomegalovirus infection. Now, the surprising thing is, infection came maybe from a close relative, maybe not from the close personal contact of prolonged duration is required for cytomegalovirus transmission. So it's not that the person got an infected graft, but his immunity was low, he did not take precautions, and though he had antibody, he still gets infected. So just like in COVID, you have antibodies against COVID, but you still can get infected. The same thing here, and that is why the wrong thing here is immunity to other strains. That immunity would not be there. C says history of cytomegalovirus infection and now in latency. Now, if you know the definition about latency, it means person will show manifestations later. So if somebody is having IgG class of antibody, that means manifestations would have already occurred. This statement, why option number C is a wrong statement, is this would be maybe valid for IgM class of antibody. That antibody has come, but the manifestations of the patient are yet to develop. Like, let me say, with respect to a little baby who's getting infection, he's still in the womb, right? The baby is still in the womb. He got infected from the mother, but those manifestations might take some time to appear. So, option number C is valid for IgM. D says IgG avidity assay helps in distinguishing primary infection from past. Well, when I read this word avidity assay, the meaning of this itself is the fact that you see a person could be having IgG class of antibody and still he could be having a new onset infection for which again IgM class of antibody will develop. So to differentiate whether he is already having previous infection, he is already having a past infection, but now he's had a new infection. The test that we do is called as IgG avidity assay. Both A as well as D statements are correct. I asked my students, how was this, multiple correct or single best response? Most guys said, sir, it was single best response. The correct answer for this question would be option number D. Though if it is multiple response, then option number A is okay, because that's the standard statement, past infection. But the point is, even if somebody is having past infection, he could still get infected. Just like we read in COVID, no? Similar kind of a description can be used to understand the logic behind why option number D is the answer to this question. So thank you so much for hearing me out, guys. There are topics from other subjects that I do take up, but I've tried to do justice to the best of my knowledge. Thanks for hearing me out.